that will happen this week at your lab sites. Paper test, 80 questions on the first 6 chapters. So chapters 1 through 6, 80 questions. You guys got this. So be good. Does anybody have anything before we get going? Any issues we need to take care of, or any questions, problems, anything for the good of the group? Yes, no, maybe. All right. I guess everybody's happy then. I like it. So you guys, tonight's work, we're going to cover chapters 9 and 10 in your book. Chapter 9 talks about lifespan development, and chapter 10 focuses on pathophysiology. So we are going to spend a very short time on chapter 9, which is the lifespan development, and we'll spend most of our time tonight on chapter 10, the pathophysiology, because that's going to get us into a lot of meat here in a bit.
Cliff.
Yes.
It's Demetria. As far as, I just thought about this, as far as us uploading like our med list and our paper, it says that it only takes 10 KBs and
That's
it won't
as big
upload.
as that's as I have selected the largest file that the college allows. And so that's one of those announcement things that I put out. So if you check on those, you'll see that I did that and told you what to do with those. So if you try to upload an assignment and it's too big, just upload it in there that you emailed it to me, and then email it to me in whatever format, and I'll get those.
Okay, I see it now.
Okay.
Thank you.
Yep. I'm really bad at attendance, guys, so I'm trying to make sure I get all of you. All right, let's talk about lifespan development then. This chapter focuses on what happens throughout the life, how the body changes, what the differences are in the body, those types of things. Real straightforward stuff, real easy stuff. As little people, by little people I mean babies, what are some physical differences between babies and adults? Anybody want to go with this?
Head size compared to their body.
Head size compared to their body. What's up with their head?
It's larger,
Okay, so
larger tone.
they have a really big head. They're quite top heavy and unstable. That's why the kids, when they first start to walk, they start to walk, and then next thing you know, they're running, and then they're falling over, trying to keep up with their head. So yeah, very large head. What else?
They have a greater surface area to volume ratio than adults.
Okay.
They compensate longer also.
What was that? Was that you, Crystal? I didn't hear you.
Yes, I said they can compensate longer also.
They can. They will compensate much longer than adults, and then when they crash hard and fast. So it's something that we need to be aware of. So because of their big head, how does that affect their airway?
Their tongue is larger, and if you bend their head back too far, it can occlude the airway.
Absolutely. So what do we do to protect against these things happening?
Put a towel under their neck.
Okay. So we want to put a towel or some kind of padding, usually between their shoulder blades when they're laying on their back, and this will help raise their body up more in line with that big head. I like that. So as children start to grow, your book goes through a lot of different age groups, and you can see those in a nice chart on page 207. It gives you some age groups all the way through life, which will show you what's going on, that sort of thing. Once kids get up into the later teenage years, through adults and into the senior citizen area, we're pretty good in EMS about dealing with those because that's who we deal with most of the time. Our problem is from the time they're born until they get to those late teenage years. That's when we have the most infrequent dealings with them. And then when we do have to deal with them, that's when we have a lot of apprehension, a lot of anxiety, because nobody gets more upset than when kids are hurt. So you guys need to be familiar with that, be aware of that, and work into these categories. In the younger age groups, all of the numbers change. So, our normal 60 to 100 heartbeat, 12 to 20 respirations, 80, 120 over 80 blood pressure type of thing. All of that stuff changes in the younger age groups. So how does it change?
The younger they are, the faster the heart rate.
Yes. The younger they are, the faster the heart rate. What else is fast?
Pulse. Oh, that's the heart rate.
Mm-hmm.
The
Heart rate.
respirations.
Yes, heart rate's faster, breathing is faster. So you'll see that in the younger age groups. When the babies are being monitored before they're born, and then once right after they're born, their normal heart rate is up around 150. So 150, even maybe up to closer to 160 would be a normal heart rate, right at birth. So if we see that, when we see 150 and 160 in 50 and 60-year-olds, we get concerned, and rightfully so. But a 150 at a little baby that's a week old is probably right in line with where it should be. So we need to be familiar, and we don't run a lot of these patients, so we don't see the dealings with those, but studying this book and these charts, that'll help you get to the point where you need to be familiar with those numbers, because they're going to speed up. Blood pressure is going to be lower than what we're normally accustomed to with the younger kids. And then heart rate and respirations are going to be much faster. Okay. So what about social and cultural differences in people as they change and grow and develop? We're mostly in the United States, most people are Christians, but not all. In other countries, the numbers may change dramatically. So into other religions. So the Christian religion is the one we're most familiar with. But what about some of these other religions? Are you guys, your book will take you into a few other cultures and religions, and it'll discuss those. What are some concerns about other religions and cultures?
Different cultures have very different gender roles. So, like a man in one of those religions, specifically like Islam, would want to be treated by a man rather than a woman, and vice versa, with a woman wanting to be treated by a woman.
Absolutely. So with some of those cultures, gender matters. It's not a huge deal in the Christian culture, and we work around it, especially in the healthcare profession where opposite genders treat patients. So it's okay for a male to treat a female or vice versa, but in some of those religions it's absolutely not acceptable. So they will refuse treatment by an opposite gender person. That could be problematic here in the United States because we don't always have both genders available on our ambulance crews. So something for you guys to consider, and consider your resources at the time. What do you have available? What can you get? Can you get the gender that you need? Maybe, hopefully, but I've never seen it. I've never seen a dispatch when you dispatch that they need a specific gender, but I could see when you get there, you would be calling for some kind of assistance, and you would have to call for a specific gender to get that done. So let's talk about let's hit the cultural side of things and the social side of things with as these kids grow up now with the vaccinations and the choice of non-vaccinations. Does anybody have a input on what's sparking and stirring and promoting so much non-vaccination now.
There's a tremendous amount of misinformation out there, and people are spreading it on social media specifically.
So social media misinformation. They're putting things out there that some of these vaccinations will cause harm and cause long-term negative effects for the children. So they're not vaccinating their kids.
Right, yeah, and people aren't fact checking when they read stuff like that.
No, they don't fact check at all. They just listen to the news or listen to what somebody puts on Facebook and they go with it. So what's the downside to that?
A lot
They're
of the
getting
diseases
sicker.
that were eradicated are coming back.
Exactly.
Measles.
A lot of these things, different things that we had under control, like measles,
Chickenpox.
polio, different things like that, they were well under control. And now there's some serious outbreaks happening in the United States. If you guys are keeping up with current events, of course on the West Coast, because that's where all the tree huggers are. But now there's that stuff's migrated to the East Coast. So New York, the state of New York, has a large population now of these small cities where people just aren't getting these vaccinations, and then you're having huge outbreaks of measles specifically. Where else do we see these outbreaks? Not just the towns where people live, but anybody have any other locations? I read an article in the news not long ago. There was a cruise ship, and there was a measles outbreak on the cruise ship. It was down in the Caribbean. It pulled into port, and the cruise ship was quarantined when it pulled into port. So nobody on the ship, nobody off the ship, and the ship couldn't leave port to continue on with the cruise. So things to think about. That's got to be a sucky vacation when you're, I mean, being on a cruise ship is probably nice, but when you're stuck on a cruise ship and you want to be somewhere else, that's, I'm sure, problematic. And so the last thing this chapter gets into is dying. Talks about dying. It talks about the stages of grief and death, and how to handle those, how to deal with those. Also, again, there's a lot of cultural issues with dying and death, the way bodies are handled, the timelines for certain events to happen. So some of these religions, how long does it take to bury somebody? How long do we take to bury somebody?
Well, it varies. It might take us 7 days. It might take y'all 3 days.
Us and y'all. So you're differentiating between white people.
You and I.
People, right?
Mm-hmm.
Yeah, exactly. Those cultures are very different, and what they do. The African American community does a lot more celebrating, a lot more gatherings,
Mm-hmm.
And they could potentially extend this event out for several days or a week or so, whereas we get it done in 2 or 3 days, right? You know, a couple days and they're in the ground and gone. There are some religions that require the body to be buried within 24 hours
Wow.
or by the next, I think it's by the next sundown from when they die.
Wow.
So there's some religions where it has to be done very quickly. And then there's other religions where and other cultures where it can be extended for quite some time. So things to think about when we're dealing with these folks. Once the death has occurred, we do have to, respectfully handle the body, but where's our focus need to be after the patient is dead?
The family.
Yeah, we need to focus on the family, the survivors, the friends and family, the people that are close to them are there, because those folks are going to be emotional in most cases, and especially if it's something that was unexpected.
Mm-hmm.
They're going to be emotional, and we need to help them and deal with them. And then don't forget your personal safety, because in a lot of cases it could be extremely emotional depending on the situation. Any questions, or does anybody have anything they'd like to add to this? Caitlin specifically?
I just think a special focus on like the children in the pediatric section in general. There's a few things when we look at that are more important to figure out fast than when we're dealing with adult patients. And one of them is, when they're going into shock. We know that children, they say they compensate, and decompensate, but what does that mean? Like, why do they do that? Does anybody know why? Has a lot to do with their size. They're smaller. They don't have the volume that we have as adults. So just a little bit of their volume loss can send them into shock, but we don't see those signs until it's too late. So recognizing any of those signs and symptoms early on and trying to get a good history on what the complaint is very important for your treatment. Also remember, just, if they are in hypovolemic shock, that can be more than blood loss. Do they have a fever, diarrhea, no urine output? So make sure we're getting those in our assessment as well. And then remember that, and in cardiac arrest in our pediatric patients, they are mostly respiratory. So we need to make sure that when we're going, in those cardiac arrest situations, we're doing our H's and T's and making sure we're checking off and finding out what causes. Was it an upper airway obstruction? Was it anaphylactic shock? What's going on that causes cardiac arrest in these pediatric patients? That was all I have.
All right. Anybody else? Questions, comments, rude remarks?
Just one thing about pediatrics. Some pediatrics will look older than what their actual age is. So that's one thing to take into consideration when you're performing your assessment and everything on them.
Absolutely. We also have all of these young children that are physically developing several years before we think they maybe should, with all of their hormone-induced chickens that they're eating and such. So, there's these kids are hitting puberty at 9, 10 years old now, instead of early middle teenage years. So bear those thoughts in mind as well as you're dealing with these kids, because they could be having some puberty like issues at a young age where we wouldn't expect. You know, most of us probably wouldn't guess that they're already in puberty. So something to think about. All right. We're gonna I will draw your attention to the end of the chapters. If you guys, and hopefully it'll help you as you're preparing over the next couple days for your module exams. At the end of each chapter, they have some review questions for you. They're multiple choice review questions. So I strongly encourage you to go through those. The answers are in the back of the book. So if you flip all the way, you know, to the back, they're chapter by chapter. All the answers are there, so you can get those. But I think it could be very beneficial for you as you're going through these chapters. All right, so let's get into pathophysiology then. This is where the molecules become a body, and all the body systems are functioning together and maintaining our homeostasis. So let's start this by talking about metabolism. There's two main types of metabolism that we need to be familiar with. One is aerobic metabolism. The other is anaerobic metabolism. Anybody want to take a stab at explaining what each or one of those is?
Aerobic metabolism and anaerobic metabolism have the same starting pathway, which is glycolysis, which is the breakdown of glucose to produce ATP. Aerobic metabolism continues further into a few other processes, mainly the electron transport chain, which is actually where the oxygen is utilized to produce the majority of the energy that the body uses.
So which process produces more energy?
Aerobic metabolism.
Aerobic. All right. We've got a little video to play for you. Hopefully this will explain things, and then we'll clear it up afterwards. Do you have that, Caitlin?
I do. I'm getting a lot of feedback. Demetria, I think it's you. Can you mute if you're not speaking? Thank you.
Did that fix it?
I think I have it to where y'all can hear on my computer. So let's see. You gotta let me know if you can't hear this. Can everybody see that? All right.
Yeah, I can see it.
Can you hear it?
Not yet. Nope. I don't have any sound for it.
All right, I just shared it. Here we go. You've got to share it once you do this part, video, sound.
I wanted to do a short video for my EMT students to help describe aerobic versus anaerobic metabolism. I always remembered aerobic metabolism because aerobic means it has air, which means it has oxygen. So we take glucose and oxygen and we make energy. The glucose needs insulin to move inside the cell, and then it goes to the mitochondria. Oxygen will then move also into the mitochondria, just diffuse into it. Inside the mitochondria, these two go through a chemical reaction, and a large amount of ATP is given off. In anaerobic metabolism, there is no oxygen, so you have just the glucose. Again, it moves inside the cell with insulin, and then inside the mitochondria, where it is broken down, and a small amount of energy, or ATP, adenosine triphosphate, is being given off. There is a byproduct that's given off, and that is pyruvic acid. Pyruvic acid is then converted into lactic acid. And in anaerobic metabolism, the cells are not getting enough energy to really live, so the sodium potassium pumps begin to fail, and we'll talk about what happens with that in another video. But we also have lactic acid buildup in the body, and the body can become acidotic. So that's a brief overview of the difference between aerobic and anaerobic metabolism.
So how does this apply to us as EMTs? Well, some organs are much more susceptible than others. So we have like the brain and the heart that will begin to die in a few minutes without oxygen. They can't tolerate anaerobic metabolism very long. Other organs like lungs, liver, kidneys, intestines can go a little bit longer, maybe an hour. And then you also have like the muscles that can go for several hours. So when we put a tourniquet on an arm, we don't really have to worry about the arm or hand or foot dying from hypoxia for several hours. And hopefully you've been to the hospital within several hours. Shouldn't take you that long to get there. So again, brain and heart can go in a matter of minutes. Other organs can take minutes to hours, and typically our muscles, skin, bones can take much longer than that.
Okay, so the biggest difference between aerobic metabolism and anaerobic metabolism is oxygen. In aerobic metabolism, you have glucose and oxygen that will produce carbon dioxide and water. So glucose and oxygen go into the cells. Carbon dioxide and water come out of the cells, and the result is energy. Energy is produced in the form of ATP, and there's a lot of energy that is produced. With anaerobic metabolism, there is no oxygen involved in this process. It's only glucose, and it forms lactic acid. What's the problem with lactic acid?
It builds up.
How do we get rid of it? It does build up. What happens when it builds up, Chris?
I mean, I'm just thinking simply of like, when you go lift weights for a few hours and that lactic acid builds up in your muscle and then, you're sore, the next 2-3 days.
That's why you're sore. So the lactic acid buildup is why your muscles are sore. So if you are working and you are sore, most likely it's because there's lactic acid buildup. Does anybody know how to get rid of lactic acid buildup? What does it take? What does the body have to get rid of it?
The potassium?
What's that?
Is it potassium?
Potassium?
Oxygen.
Oxygen, yeah. The one thing that the body didn't have to make the lactic acid it needs to get rid of it. So oxygen is what the body needs to get rid of the lactic acid. So in the meantime, if you have the lactic acid buildup, you're going to have sore muscles, and then you're going to need to introduce a lot of oxygen to work that out and break down that lactic acid and get rid of it. So that's the big difference between the two forms of metabolism. So if the body has a lack of oxygen, what do we call that?
Hypoxia.
Hypoxia. There are 4 reasons for hypoxia. Your book does a good job of explaining these over way too many pages. But 4 reasons for hypoxia. Anybody want to take a stab at one?
Well, the first one that the book lists is oxygen delivery to the blood, and a number of factors can impair that, including a lower percentage of oxygen in the atmosphere for whatever reason, whether you're stuck in a closed area with some sort of combustion going on, or you're at a high altitude where the pressure is lower, or simply you have an occluded airway, so you're just not getting the oxygen.
Okay, so impaired onloading of oxygen into the blood. So that is the first way to have hypoxia, and Mark gave us 2 or 3 reasons for that. So that is the point where oxygen is being taken in to the respiratory system, and that gas exchange is happening in the blood. What's the next one? Anyone?
Does it have to do with the transport within the bloodstream?
It does. And what are we dealing with there? What system?
Red blood cells?
What system are we
Oh,
dealing with?
circulatory system.
Yes, the circulatory system. So impaired transport of the blood. So we get the oxygen into the blood cells, and then we have to transport it through the body. So the blood is going to do that, but the circulatory system is what makes that happen. So what are some reasons for impaired transport?
Being anemic?
Carbon monoxide poisoning.
Carbon monoxide poisoning makes it more difficult for the oxygen to attach to the red blood cells. Anemic is low iron. So what's moving the blood through the body?
The heart.
Yes. So any issues with the
Cardiac
heart?
arrest they have listed in the book.
What's that?
They have cardiac arrest listed in the book under that one.
Exactly, because if the heart is not beating, the blood is not moving. So that's the big thing with the delivery the transport of the oxygen through the blood. If you're having cardiac arrest, your heart stops beating, blood stops moving, so then that oxygen is not going anywhere. It's just stuck in those red blood cells for the moment in the blood, and it's just sitting there. So that's the biggest one, the heart and the circulating of blood. So cardiac arrest, most definitively. Other cardiac issues with contractibility and the ability to pump and leaking valves and things like that could play a factor in here as well. What's the third reason for hypoxia?
Could you hear that?
Nope.
I didn't think so. Oxygen transport from the bloodstream to the cells.
Yeah, that was the second one that we did, oxygen transport. What's the third one?
Cellular oxygen utilization.
Say again?
My book has cellular oxygen utilization.
One before that.
Before that, I have oxygen delivered to the cells.
Exactly. So we loaded the oxygen in the lungs, we transported it in the blood through the body, and now the oxygen is at the cells. So we have to offload it into the cells. So there could be some issues with that offloading process. And that's what your book is getting at. It talks about some particular diseases that could do that, or different pH states that could cause that type of problem. And so we have it there, we loaded it, we delivered it, but now we can't really unload it. That's the problem. And then the last one you talked about, Chris, is cellular oxygen utilization. So that is the cell's ability to use the oxygen once it has it. And the book gives you an example of cyanide. That is their biggest example of the cells not being able to use the oxygen once it's there. So if that cell is saturated with cyanide, it won't be able to pull that oxygen in and use it. So that's one of them. Okay, so oxygen, obviously we all know that the body has to have it. We know how it gets in the body. We know how it moves around the body. And we're learning what the cells are doing with it in those aerobic metabolism processes. It takes the oxygen in, it mixes the oxygen with glucose, and then it creates energy. Is everybody good with this process? So when the body is in a hypoxic state, it's starved of oxygen. So for the energy side of it, it can switch processes from aerobic to anaerobic it will still generate energy, just not nearly as much. The anaerobic process does not generate very much energy at all. It does generate some, but it's a small amount. And it also generates that lactic acid we were talking about, which becomes problematic if you don't reintroduce oxygen to deal with that and break it down and get rid of it. So those things are stuff to think about with oxygen, and why we need to keep oxygen on board and keep everything at that good level. So now let's talk about glucose, the glucose side of things. I think Caitlin has a video for this as well.
This is just a really quick video on diabetic ketoacidosis. And there's one phrase when I was looking through different videos that I really liked that they used here. So we'll watch it, and then it goes a little bit more into DKA than like insulin and whatnot. But just, we'll watch it and we'll discuss it.
So you have type 1 diabetes. It's something you're going to manage mostly with insulin, a hormone your body doesn't produce when you have type 1 diabetes. By now, you probably know how and when to give yourself insulin. And if you have an insulin pump, you probably know how to maintain it. But do you know how to tell if something's not working? That's what we'll be looking at. You eat carbohydrates to fuel yourself with energy. Your body breaks down the carbs into sugar, which then goes into your blood. Think about it like filling up the gas tank in a car. When you eat, your body stores the carbs to use as energy when you need it later, like filling up the gas tank. Insulin is what opens the tank to let the gas in. As someone with type 1 diabetes, you don't produce insulin naturally, so the sugar doesn't get to where it's supposed to be, which is why you take insulin. If you're not getting the insulin you need, the sugar you eat stays in your blood instead of being stored in the tank. When this happens, your body won't have the fuel it needs when it needs it, and your body will seek out alternative sources to break down into fuel. One of the first sources it looks for is fat. Except when your body breaks down fat, it leaves ketones in your bloodstream that make your blood acidic. Together with high blood sugar, acidic blood from the ketones can make you sick and put your body in a state of diabetic ketoacidosis, or DKA. And DKA is really, really serious. It can even be fatal. The most common reasons for DKA happening are developing type 1 diabetes, missing taking your insulin, getting an infection, and malfunctioning equipment. Your body will give you plenty of pre-DKA warning signs before you're in serious danger. You may
So the main part that I wanted you to see in that video is when they were showing the picture of the car filling up with like the insulin and saying the glucose. I really liked how they broke it down and said that we have those stores, but if we don't produce insulin, then our body is not able to use those glucose storage. So our body, we don't have that energy source. So then it goes and eats, turns down the fat, which builds up the ketones in our body. So that was just a really eye-opening thing to me, because I think we've all heard of DKA and it's bad for the body, but it's never said really why and why that insulin was there and how did it get that glucose for our body to use. Because DKA is definitely something that when we see it in our patients, they need treatment fast. So recognizing those signs and symptoms. So if you see somebody in DKA, how might they present to you?
Extremely high blood sugars
Okay.
that may be topping out your glucometer.
So you might get that reading that says high. Yeah.
Some of them you can smell them.
What do you mean you can smell it?
Their breath smells sweet.
Yeah. So it's kind of like that acetone fruit smell. So sometimes you might get dispatched to a call. An officer might have pulled somebody over and said, possible ETOH or possible alcohol on board, and you get there and they smell this fruity kind of alcoholic smell, and that's their body. That's one way that they're trying to get these ketones off, is they're blowing them off. They're trying to get rid of them that way. They can also be altered because their ketones are so high, and they could be, violent. So they also might think that they're drunk because they're violent. So yeah, so recognizing and differentiating the signs and symptoms of DKA with your patients is definitely important.
All right, a couple more things to talk about. Let's talk about some other systems in the body. This is not specifically in this chapter in the book, but the sympathetic and parasympathetic nervous systems, they're coming in another chapter or two. And so let's get a discussion in on these real quick on what they're doing with the body and how the body's reacting. Anybody care to explain the sympathetic nervous system?
It's part of the autonomic nervous system, so it does what it does without you thinking about it, and it's in charge of the fight or flight response.
Right. So how's the body reacting when this is happening?
Increased heart rate, dilation of pupils, dilation of blood vessels, dilation of bronchioles.
And produces adrenaline.
Okay. What about the parasympathetic nervous system?
It's another part of the autonomic nervous system. So similar to the sympathetic, it does the opposite, and it's considered to be in charge of rest and digest functions.
Exactly. So how does that affect the body?
After a meal, stimulates digestion, diverts blood to the intestines to extract the nutrients, slows heart rate and respirations, kind of conserve energy.
So in essence, these two systems work opposite of each other. The sympathetic system will stimulate your vital organs to produce, to function, to move, run, fight, do those types of things, where the parasympathetic nervous system will adjust functions for relaxing, digesting, chilling out. This is when your body comes down, all the functions of everything that's stimulated in the sympathetic nervous system is relaxed, and then the digestion process, the sleep process, those types of things are more in operation. So let's see if we can watch this real quick. Are you guys able to see that?
Sympathetic nervous system, fight or flight. This system gets activated in times of stress to keep us alive.
What the?
Sympathetic nervous system is rest and digest. It gets activated to help us in times where we need to rest and digest. All right, first thing is when we look at the brain, brainstem, and spinal cord, if we just focus on the sympathetic nervous system, you'll find that all the fibers for the sympathetic nervous system that leave the spinal cord will leave at either the thoracic or lumbar regions of the spinal cord. All right, so only those two particular regions. This is another reason why the sympathetic nervous system is also called the thoracolumbar system. You can see these purple fibers here are those fibers exiting for the sympathetic nervous system. When we look at the parasympathetic nervous system, it's also termed the craniosacral because the fibers for the parasympathetic nervous system will leave at either the cranial or sacral region, and therefore they're called the craniosacral portion of the nervous system. All right, so that's the first thing. Second thing is this: if we were to just focus on the sympathetic neurons leaving the spinal cord at the thoracic or lumbar region, you'll find that predominantly the very first neuron that exits is a very short neuron. Now, for both sympathetic and parasympathetic nervous systems, it's a 2-neuron chain from the spinal cord. All right, have a look. So this is parasympathetic. One neuron then speaks to the second neuron, then speaks to the organ. Sympathetic. One neuron speaks to the second neuron, speaks to the organ. And that's going to be for all of them except this one. I'll talk about that one in a second. All right, so sympathetic nervous system, the first neuron in the 2-neuron chain is short. The second neuron is long. For the parasympathetic, it's the opposite. The first neuron in the chain is long, and the second neuron is short. So that's one difference. All right, the first neuron is always termed the preganglionic neuron. The second neuron is always termed the postganglionic neuron. A ganglion is a cell body that sits outside of the central nervous system. There it is. There it is. There it is. There it is. Therefore, this fiber is going to be termed the postganglionic neuron. All right. The other thing is this. Every single one of these preganglionic neurons, all right, is going to release a neurotransmitter to speak to the postganglionic neuron. It doesn't matter whether it's parasympathetic or sympathetic. So let's have a look. This is a parasympathetic preganglionic neuron. To speak to the next one has to release a neurotransmitter. This preganglionic neuron for the sympathetic has to release a neurotransmitter to the postganglionic. The thing is, regardless of whether it's sympathetic or parasympathetic, the neurotransmitter that will be released from the preganglionic neuron will always be acetylcholine. So it doesn't matter whether it's sympathetic or parasympathetic, it's always acetylcholine that's being released from the preganglionic neuron to speak to the post. So that means acetylcholine must bind to acetylcholine receptors. There's two major types. There's nicotinic and muscarinic. Right. In this case, the receptor that's always sitting on the postganglionic neuron, ready to pick up acetylcholine, will always be nicotinic receptors for both sympathetic and parasympathetic. So far, there's no difference in the neurotransmitter or receptors used between fight or flight versus digest. The differences now come as we follow down the postganglionic neuron to its target organ. So remember, what target organs are they going to affect? Well, remember, sympathetic, fight or flight, pupils dilate, heart rate increases, airways open up, digestion decreases, peripheral blood vessels constrict. These are some of the functions that are going to happen. For parasympathetic, because it's rest and digest, pupils constrict, airways close up, heart rate slows down, digestion increases. Okay? So, let's have a look at this parasympathetic postganglionic neuron. It's going to release, again, acetylcholine. So that means all parasympathetic nerve fibers, doesn't matter whether it's pre or post, will always release acetylcholine. The preganglionic neuron releases acetylcholine and will bind to nicotinic receptors. The postganglionic neuron will release acetylcholine and bind to muscarinic receptors. Nicotinic first, then muscarinic at the organ of parasympathetic. For sympathetic, well, we know that fight or flight comes with that adrenaline rush. So that's the hint here. You've got acetylcholine released from the preganglionic to the post, binds the nicotinic receptors, activates the second postganglionic neuron. That releases neurotransmitter, which is not acetylcholine, but is noradrenaline, and then that will bind to noradrenaline-specific receptors, which we term adrenergic receptors. Okay? Now, the only difference here is for the sympathetic nervous system, there is a single preganglionic neuron that goes all the way to the adrenal gland on the kidney gland. The neurotransmitter that's released is going to be acetylcholine, even though it's not there. It's acetylcholine that's released and binds to nicotinic receptors, and that releases adrenaline into the bloodstream to activate the rest of the sympathetic nervous system. So that means the preganglionic neuron that travels to the adrenal gland releases acetylcholine, binds to the nicotinic receptors on the adrenal gland, but then it releases adrenaline. So that means the adrenal gland acts as a postganglionic neuron. So these are the major differences between sympathetic and parasympathetic nervous systems. Hi, everyone, Dr. Mike here. This video, we're going to have a look at the anatomic.
Okay, so the major differences are the functions that they control in the body, but the cool thing is the acetylcholine. When the acetylcholine is released and picked up by those transmitters, that is going to play a big part when we get into pharmacology. So we're just kind of giving you guys a heads up and a building process, because there are some medications that are going to have some effects on the acetylcholine, whether it helps it or inhibits it from working. So you'll see that coming in the near future. And then when we're talking about receptors, I want to hit you guys with one other thing real quick about receptors. We have alpha and beta receptors. And if you guys are not...
So this is going to be my third and final video to do this. So a lot of people get tied up with alpha and beta receptors. However, you're not alone. It takes a while.
My computer is moving so slow right now. I want to share with you guys about alpha and beta receptors. We're going to see what alpha and beta receptors do. There's two of each. So we have alpha 1 and alpha 2 receptors. We have beta 1 and beta 2 receptors. So let's just take a quick listen to this guy, and he will discuss those, explain it. If you're not familiar, you will be soon.
This is going to be my third and final video to do this. So a lot of people get tied up with alpha and beta receptors. However, you're not alone. It takes a while to get used to these. However, do not worry. You can definitely get through it. So I want to explain the alpha and beta receptors to you in a better format. And so when you think of alpha and beta receptors, why is this important? It's actually really important because we're going to talk about drugs that have alpha properties and we're going to have drugs that have beta properties. And you've got to know what they do, especially if someone says to you it's an alpha 1 drug or a beta 2 drug, especially when we'll get into practice as practitioners. We will prescribe beta 2 drugs and we may prescribe an alpha drug as well, an alpha 2 drug. So the most thing to start off, you have one heart, okay? So think to yourself, one, if there's going to be a receptor that's it says beta 2 properties, and so if it's a beta 2 drug, it's going to affect lungs. So you think to yourself, you do write this out: A, B, C, D, just like the alphabet. To help you more do some concepts, you can write alpha right here. So we can write alpha for A. For B, we're going to say beta. For C, we're going to say constricts. And for D, we're going to say dilate. So you can have alpha 1 drugs. And you can also have beta 1 drugs. And for other purposes too, you can also have alpha 2 drugs. You can also have beta 2 drugs. So when it comes down to this, A always goes to C, B always goes to D. Okay, so alpha is going to constrict, beta is going to dilate. Okay, so alpha 1 receptors, or if a drug that has alpha 1 properties, so alpha 1 heart, alpha is going to constrict, so it's going to constrict the heart. If it has alpha 2 properties, it's going to lungs, it's going to constrict the lungs. If it has beta 1 properties, it's going to, beta is going to dilate. So 1 heart, beta 1 heart, it's going to dilate. Beta 2 lungs right here. 2 lungs, beta 2 is going to dilate. So example of beta 2 drug would be specifically albuterol. Albuterol is a beta 2 agonist that is going to work on dilating the lungs. Okay. An example of an alpha 1 property or a drug I can give you is Levophed or norepinephrine. This will constrict the heart. So in our practice, we're going to give drugs that we're looking for effects that either constrict to alpha properties or they're going to dilate to beta properties. So I know that this way may not be the best for you. So I have one other way that can help you out, thanks to my good friend Jen. So here's another way to write this.
So that information is going to come in handy in the next half hour when we're going over your medication list that you guys worked on this week. But it'll also help you in the future when we're talking about the different receptors. So to finish this pathophysiology, we're going to have a big lesson on shock. That's what the rest of the chapter covers. So there are 3 different stages of shock. So let's first define shock. If somebody could, what is shock?
Shock is defined as hypoperfusion, or essentially inadequate oxygen supply to tissues.
Okay, so in the most simple terms, inadequate oxygen supply or hypoperfusion. And so there's 3 different stages of shock. We have compensated shock, decompensated shock, and irreversible shock. So in compensated shock, what's happening?
The body organs are compensating for the loss of the other ones. So it's putting a strain on the other organs in the body.
So the body makes an adjustment and it's working. It's adequate, it's enough of an adjustment. So the compensated shock, the body will make that adjustment and it'll be working. What do we normally see happening in compensated shock? What are some signs that, what do we see the body doing?
Heart rate increases.
Yeah, typically that's going to be one of the first signs you see is a heart rate increase. What is the body trying to maintain? You guys
Blood
know?
pressure.
Blood pressure. So the first thing it's going to do is increase heart rate to maintain blood pressure. If that increase works, then we'll call that compensated shock. If the increase in heart rate doesn't work, then we move on to the next stage, which is decompensated shock. Okay, so that's when the adjustment by the body is not able to maintain the blood pressure, and so we enter decompensated shock. That's the second stage. And what's the last stage is irreversible shock. So what does that define as?
It's to the point where it can't be fixed. It normally ends in death.
Okay. So once they hit irreversible shock, there is cell death, there's permanent tissue damage, and usually whatever actions we're trying or whatever treatments that are being done, they're not going to be successful. So once you hit the point of being in irreversible shock, you're going to die. So 4 categories of shock. There's 4 primary categories of shock.
Obstructive, cardiogenic, distributive, and hypovolemic.
Okay. So we'll take hypovolemic first. That's the easy one. What is hypovolemic shock?
Loss of volume.
Okay. And does it matter what the reason is?
What you mean, does it matter what the reason is?
Why we lost the volume? It matters long term, but in the short term, it's not going to affect how we fix it. So hypovolemic shock, we have lost volume. So what's the fix for that? Fluids. That is the fix. So we are going to start an IV on these people. We are going to give them fluids. That's the fix. If they are bleeding and we can see it, what's the fix for that?
Quick clot.
Could be one fix. What else?
Bandaging.
Okay. What if that doesn't work?
Tourniquet.
Yes. Yes. So if they're bleeding and we can see it, we need to stop the bleeding and stop it quick. So bandaging, direct pressure type of thing. If that doesn't work, we can use the hemostatic agents like quick clot or tourniquets. We're getting into much quicker now. If it's bleeding that we can't see, if it's internal bleeding, what do we do with that?
Load and go.
Okay. So we're going to transport them to a facility that can get into fixing them. So they're going to, if they're bleeding internally, they're going to need surgery. So we need to get them to a facility that can do the surgery. In the meantime, our fix for that is to start IVs and give fluids. How much fluid do we give them?
And it blood pressure depending.
Okay, what blood pressure are we looking for?
At least 90 systolic.
90 systolic. All right. So we're going to give fluids based on blood pressure. We're going to try to maintain a blood pressure. And if we cannot maintain that blood pressure, what are we going to do?
Rapid transport.
Rapid transport and give more fluids. So that's hypovolemic shock. Loss of volume, which typically means they're bleeding somewhere. So either externally or internally. And then we need to do volume replacement. So we will give them fluids at this level. All right. So what about cardiogenic shock?
It has to do with the heart.
Okay, more specifically, what's wrong with the heart?
Either pumping too fast or too slow.
Or not at all.
Well, it's probably not going to be too fast. So what's wrong with the heart? Heidi says the pump's broke. So yes, it is. And usually it's too slow. It's not too fast. So something is wrong with the heart. It's not pumping a sufficient amount of volume through it, and it's not getting that circulation through the body that we need. Typically, this is what happens when you have a heart attack, and that'll affect the blood flow coming out of the heart and its ability to pump. As hearts wear out, their contractibility, their ability to squeeze and force a sufficient amount of blood through it becomes an issue. So there's a couple different things that can be causing this. So it's going to depend on what's going on with them as to what the fix comes out to be. If it is a heart attack, what's the fix for that for us at the A level?
We give 4 baby aspirin.
Okay. What else?
And if that don't work, if their blood pressure can hold it, we give them nitro if they have not taken any enhanced male or female enhancement drugs.
Okay. What else?
Epi.
Did you say epi, Mark?
Yeah.
Okay, let's not do that just yet.
That was a shot in the dark. I wasn't sure.
Okay. Not quite. One more thing, you guys. Demetria is given aspirin. She's given nitro. One more thing that you guys need to give these patients.
So break it down. So if we're talking about MIs, we're talking about infarction, right? Or ischemia. What's infarction? It's okay if you don't know. What's infarction?
Is that occlusion, like stopping up, clotting?
Yeah, it's tissue death. Okay, so how does that tissue die? Why does that tissue die?
Lack of oxygen.
Lack of oxygen. Okay, so we're going back to our anaerobic and aerobic metabolism. What's our fix? If we don't have oxygen, we build up bad stuff, right? So what do we want to give that patient? Oxygen.
Yes, oxygen. So for these MIs, if your patient is having an MI, oxygen is one of the things we want to load them up with, because that's one of the things that they're missing. And then the aspirin and the nitro will help with the heart function. So if they're having an MI, most likely there's a blood clot somewhere in the coronary arteries. And so the oxygen will help with preload. The aspirin will help try to bust up the clot wherever it is. And then the nitro will help with the heart muscles. So those three medications you guys have, and you can give those for that. What about distributive shock? Does anybody have an explanation for distributive shock?
Well, distributive shock have to do with the blood vessels and how they lose their tone. And it's distributed throughout the whole body system.
Okay, it is distributed. That is why it has that name, because it spreads out amongst the body. The best example that they have is anaphylaxis. Okay, so somebody that's having anaphylaxis, those histamines are functioning in overdrive, and they're having this reaction in their body, but the reaction is usually an allergic reaction, could be localized, but when it becomes anaphylaxis, it is distributing through the body. It is spreading. And usually to be anaphylaxis, it has to include 2 body systems. Okay, so that is the key to anaphylaxis. That's why it falls into a distributive category. Neurogenic shock also falls into a distributive category, as well as septic shock. So these are all spreading through the body, and they're usually covering more than one system as they go. The treatments are going to be very different depending on what it actually is. So we'll get into those later on, but your understanding of what the shock system is and what it's doing is most important now. And so the last one that we have is obstructed shock. Anybody want to take a stab at this?
Is that like a blood clot?
It is. It could be like a blood clot. So something like a PE would be obstructive. It's the same as distributive. It's exactly what it says and what its name says. So obstructive it means that things are being obstructed, so they're being blocked or cut off, just like what a PE would do. also, what does a tension pneumothorax do?
Does it cause the lungs to collapse or not work as effectively?
Yes, not work effectively. So it will block them. That air that's escaping into the thoracic cavity will actually block the lung from being able to expand and contract. And essentially, it will not, after you get enough tension in there, it will not function. And then the last example they give you is the pericardial tamponade. Does anybody want to take a stab at what the tamponade is?
Isn't that blood surrounding the heart and the pericardial sac?
Yes. Blood is leaking into your pericardial sac around, which is that sac around the heart. And so as it fills into that sac, it prevents the heart from being able to contract. It squeezes on the heart, and it doesn't allow the heart to contract as it should. It's if you guys understand what snakes do, a boa constrictor, do you know how a boa constrictor kills its prey? Anybody into snakes?
Strangle them?
Not strangle.
It constricts them. It crushes them.
So it wraps around them and it squeezes. And every time they inhale, it squeezes a little more. So that they exhale, squeeze, and then they cannot inhale as much. So they inhale a little less every time until they suffocate. So it'll just squeeze them every time it tightens up with their inhale, exhale, and it'll squeeze tighter and tighter and tighter. So every time their inhale is just a little bit less until they don't have any. So it'll suffocate them. That's exactly what's happening with the heart and the tamponade. So that blood is leaking in there, and as it fills that sac, it kind of suffocates the heart so that it can't contract and pump the blood out. We do have a specific fix for that at our level. Anybody want to take a stab at what our fix is going to be if we recognize this problem? This is a little early in our course, so bonus points if you get it. Come on, Heidi. No. Anyone? Nobody yet? All right. So if you, and we'll get into this more later on about the signs and symptoms of tamponade, but if you get into this situation, the fix for this is going to be to push IV fluids. All right. Pushing IV fluids. So the last patho thing, your body does talk about hot and cold situations. How does your body regulate temperature?
By sweating.
Okay. So
Through
that's
the
how
skin.
that's one way to cool. What'd you say, Chris?
Regulates through the skin.
Through the skin, yeah. The skin is the the temperature regulator. So if you're working and your body's generating too much heat, it needs to get rid of that heat. So the way that it does that is, one way it does that is by sweating. How does it, that's how it cools off. How does it stay warm? How does the body stay warm?
By shivering.
Okay.
Shivering.
Shivering. That's one way. It generates heat by that motion. So in cold situations, the body is going to conserve heat as much as possible. It's also going to deflect and reroute blood flow. So it'll keep the blood away from the extremities, more to the trunk, more to the vital organs, as opposed to the hot, where it's sending everything out as far as it can to cool it off, and then it'll bring it back in as cool and reduced blood. Real basic stuff, real easy stuff. We're getting more into the advanced level stuff. So this patho chapter gets into the cellular level of functions. It gets down to the neurotransmitters and different things like that. So you'll see that as you read through this chapter. Quite in depth it goes, which is one of the reasons we showed you some of these videos to break it down to the cellular and neurotransmitter level for you. We're trying to tie this all together so that you can understand what the body's doing, and then when we start giving these medications, what effects that they're having on that. Anything else, Caitlin?
No, I think like the heat and cold emergencies will be dealt a lot more in the environmental emergencies,
Yeah,
which is why they only cover it. Yeah, they only cover a little snippet of it. Basically, they're just telling you to give them oxygen if they need it in this part right here.
Right, right. Okay, so we need to go over these medications that you guys have been working on this week. So you had a list of 4 medications: aspirin, nitroglycerin, albuterol, and ipratropium were the 4. We're going to go through each one of these, make sure everybody has the right information on their drug cards, and that way you're studying and learning the right information. We want to get all of this stuff correct for you. So does somebody want to take aspirin? Let's start with aspirin. Someone want to give us the rundown: names, indications of use, contraindications, dosages, routes?
All right, I'll do aspirin.
Okay, go Derek.
It is a platelet inhibitor, an anti-inflammatory medication. The indications are sudden onset of chest pain, MI. Contraindications are ulcers, of course, allergies to aspirin, and possibly asthma is what I got.
Okay. What's the
And it
dose?
said what I do.
You have a question?
Yeah, on this it says interactions on the medication. It says use caution with NSAID allergies.
Yes.
Why is that?
That's aspirin is commonly mistakenly taken as an NSAID. It's not an NSAID. It's like you said, it's a platelet inhibitor.
Okay.
It does have some analgesic properties, but the thing is with the asthma, the NSAIDs and the aspirin have the same effects on the asthma.
Okay.
So people that have asthma, they could have a condition that's called aspirin-induced asthma, or asthma attack. And so what that does is when you give them aspirin, there is some cells in the body called leukotrienes that the aspirin will let those things run wild in the body.
Okay.
And that will trigger the asthma attacks. And in some cases, and it's very, very rare, but in some cases, those asthma attacks can be fatal.
Okay.
So,
all right, I got supplied by like chewable tablets.
Yep.
The dose of it is 481 milligrams, and it's 325 milligrams.
Okay. So
max dose.
So the dose could be a lot of places will say 325 or 324. It's just depending on how they supply it.
Okay.
You could take one. If you get like a bottle of Bayer aspirin, the regular strength Bayer aspirin, they are 325s. So you could take one of those and swallow it. But they like the chewables because you chew them up and they're kind of absorbed faster in the mouth when you're chewing them up. And so we do those. Plus, we don't have to give them anything to drink. So that's why we're carrying the chewables. And so 4 of those 81s, 324 would be the thing. The route is PO because it's taken orally. Any other contraindications out there? He talked about ulcers, caution with asthma.
Any blood thinners?
Okay.
GI bleeds.
GI bleeds, blood thinners. Sometimes you'll hear people say recent surgeries. If they're saying recent surgeries, they mean very recent, like within, 1 or 2 days, not like, I had surgery last month. It's recent as in very recent because it's a bleeding. We're looking at the bleeding things. With the platelet inhibitor, this is keeping those platelets from sticking together. So what it'll do is promote bleeding. And it will inhibit the forming of blood clots. So that's why we're giving it, because
Can you talk a little bit on, I hear this a lot. So say they go to a patient that has already taken their 81 milligrams in the morning, like they always do, and they go to a patient with a chief complaint of chest pain. If they've already taken one that morning, how much should they give when they are doing their patient assessment?
We should still give 325 or 324, correct?
It's going to matter about time frame, and I would tell you that if it's been probably more than an hour, I would give the whole dose. That's terrible. Whoever did that, you're terrible.
You're welcome.
So yeah, give the whole dose. Unless they take it while you're en route and your dispatch tells you that they've taken it. If they say, well, I take one every morning, we're still going to give them the whole dose.
I see that a lot. People go, I only gave 3. And why? Because they took one in the morning. Like, well, it's nighttime. It's okay.
Yeah, that's right.
A lot of our population takes that aspirin in the morning.
Yeah. After about an hour, I would give the whole thing. Okay. Any other questions about aspirin? All right, let's talk about nitroglycerin. Who wants that one? Come on, somebody.
I'll do it.
All right, Mark.
Its classification is a nitrate, or also known as an anti-anginal. The dose is 0.4 milligrams, which is typically 1 spray or 1 tablet, or a 1/2 inch to 1 inch if it's a paste, which I know we use in Chowan. The route is sublingual, or if it's a paste, it's topical. Side effects can be headache, dizziness, or hypotension. Indications are angina pectoris which is chest pain or chest pain associated with a myocardial infarction. And contraindications are children less than 12 years old, hypertension, and recent ED medication use. Or I guess I could say within the last 24 hours, as opposed to recent.
Okay, so you said a whole lot there.
Yeah.
So it's a nitrate. That is the class. And what does it do?
Dilates blood vessels.
It dilates blood vessels. Okay. So what effect is it going to have on the body?
It's going to drop the blood pressure.
It is. It's going to drop blood pressure. So we have a few different routes to give this medication. You can give it sublingual, which is a dissolvable tablet under the tongue. The dose is 0.4 milligrams if you're doing it that way. This does come in a spray. Is anybody carrying the spray on their trucks? I feel like probably not is the answer. But people will have this at home. They'll have it in spray form at home. And then the paste, which a lot of ambulances are carrying, the paste is going to be dependent upon blood pressure. Okay, so depending on their blood pressure is how much paste you put on. Typically, it'll be 1 inch to 1.5 inches, but the way that the paste works is so if their systolic blood pressure is over 100. They get 1 inch. If their systolic is over 150, they get 1.5 inches. And if for some reason their systolic is over 200, we'll give them 2 inches. And 2 inches is the max.
Be mindful when you are giving nitro paste that typically look at manufacturer recommendations on your package, but one package is typically 1 inch. Don't try to take one package and squeeze it because you can get 2 inches out. It's not 2 inches of that medication. So make sure that you are going by your manufacturer and recommendations on your medication as part of your rights of your drugs. Look at it, make sure that if you need 100 or 1.5 inches, that you're using a pack and a half.
And which route works faster? Does anybody know?
Sublingual.
Sublingual versus the transdermal. Derek's got sublingual. Anybody with him? Yeah, you got some takers, Derek. So, yeah, sublingual is faster. So if you're putting the paste on, it's going to take a little bit longer for it to absorb and go. I just got a message that says my speaker doesn't work. Can you hear me? You can still hear me? Okay, good. I'll ignore it then. All right. So, so what are the contraindications again for nitro? What did you say before, Mark?
I just said hypotension in general, but I see that Heidi put a message saying not given with systolic blood pressure less than 100, which is true.
Okay.
Yeah.
So
and then
so hypotension, but we do have a specific number to follow.
90.
And there is some
Systolic.
leeway. There's some leeway in this, and it'll be based on protocols. Some you'll see 90, some you'll see 100, and so that'll be based on your local protocols there.
Isn't like an intracranial bleed or like head trauma?
Yes.
Contraindication as well?
Yes.
Okay.
Anybody want to take a stab at explaining that?
Because it's a vasodilator and it'll make it bleed more.
Okay.
You also don't want to give it if they've had Viagra or some Cialis or some kind of female enhancement drug, because it could lower the blood pressure too low.
Okay, so Mark hit on those as well. He said recently, and then he said like 24 hours. Some of those are lasting and acting longer than 24 hours. So be careful on those. They could be up to 36 or 48 hours, depending. What's the reason for not giving nitro with those medications? You know?
Because aren't those medications, don't they do the same thing that nitro does?
Yes.
So you're double dosing basically.
Right. Those medications are also vasodilators. So we're vasodilating on top of vasodilating, which could lead to a very low blood pressure.
I like Heidi's answer because it vasodilate. Yes, it vasodilate.
You're gonna vasodilate if you do that. You may die a lot. So any more contraindications for it? Head trauma, sexual enhancing drugs, low blood pressure,
Children.
don't get it. What if you're this is some characteristics of it. What if you give a sublingual nitro to somebody and their blood pressure does not drop and they don't get a headache? What does that mean?
Probably wasn't absorbed into the bloodstream.
Nope.
The blood pressure's higher than you thought.
Nope.
Is it expired?
Maybe.
They take another medicine that cancels that one out.
No, this nitroglycerin is a highly sensitive medication. It's sensitive to heat and light, which is why it's in a brown bottle. And typically it does not last very long once it's open. So if you give this medication, you should expect blood pressure to drop to some degree. You should expect your patient to get a headache. You should have some expectations of what this medication is doing. If none of those things happen, I would dare say that your medication is no good. So it's probably been exposed to light, heat, may be expired. It's been open more than a few days. And so I would suggest you get some new medication. All right. Anything else with nitro before we move on? Okay, that takes us to albuterol. Who wants this one?
I'll try that one.
Okay.
Albuterol, the class is a sympathomimetic. The description is a bronchodilator or bronchodilation. Indications is asthma, COPD. Contraindication is tachycardia, hypersensitivity, and precautions. Some precautions is cardiac history. Some side effects is a headache, dizziness, and nervousness, make you anxious. The dose is for adults 2.5 to 5 milligram or 3 cc's via nebulizer, up to 3 doses. And for pediatrics, 1.25 to 2.5 milligram via nebulizer, up to 3 doses. And it's a class C for pregnancy.
Okay, so let's go back to the class. You said a sympathomimetic.
Mm-hmm.
Anybody else have a different class for it? Does everybody have that on their drug card as the class? Heidi says it's a beta agonist.
It's on page 264 in chapter 11.
Okay. And you're right. You're both right. It does those things that it does. Okay. So it is a sympathomimetic, but it is a beta agonist. And specifically, which beta is it affecting? Tasha's got this. Yes, beta 2s. Okay, so it is it's working on these beta 2 receptors. So based on that video that we showed you earlier, what is it doing to the body?
It's a bronchodilator.
Yeah, it's a bronchodilator. So with the beta 2s, it is dilating the lungs, based on that video earlier. So that's how it works. Good deal. Indications: asthma, COPD. What else? What type of lung sounds would you hear? Anybody know?
They got it in the chat. They said wheezing.
Wheezing from Tasha.
Okay, I got you. Wheezing, wheezing, wheezing. Yes. So wheezing lung sounds, asthma, COPD. This is what we're giving it for. She got the doses correct. The adult dose 2.5 to 5. How is it supplied? Do you guys know? Don't say 1 tube.
It's inhaled.
Do you guys know how it's supplied in that tube? How much is in that tube?
3 cc's.
3 cc's. How much medication? How many milligrams?
2.5.
2.5. That's right. So 1 dose is 1 tube for the adults. And then for the children, you can do a half or you can do a whole tube. So 1.25 to 2.5 range. So a half to a whole. Side effects is tachycardia, anxiousness, jittery, that kind of thing. So be careful. It tells you to be careful with increased heart rates and cardiac problems. The reason is because it's going to make your heart rate go up. So albuterol increases heart rate. So if they already have a high heart rate, that's problematic. And if they have cardiac disease, that could also be problematic. What about ipratropium? What does that do? This is the last one. Who's got it? Come on, one of you silent peoples. Okay, Crystal, I'll just make you do it. Do it, Crystal.
My cards are in the car.
What?
Hold on.
You got to go to your car?
Yeah.
Oh my gosh, we don't have time for that. We got to get out of here. Come on, Heidi. You got ipratropium? I see you, Heidi.
I think she's typing it out.
Don't
Heidi, unmute.
Unmute and talk. You guys are killing me. just flat out killing me.
Can you hear me?
Yes.
Okay, because something's wrong with I don't know if it's our internet or your internet or whatever.
Okay.
Anyway, your ipratropium it binds to the albuterol.
What's the class for it? What drug class?
It's a shoot, my battery's getting ready to die. It's a vasodilator. No, it's not a vasodilator.
No, it's not.
The constrictor.
Bronchodilator.
No.
Huh?
Somebody want to help her out?
Bronchodilator.
No.
Bronchodilator.
No.
All right. Heidi, I'm going to help you speaking your squirreling.
Yeah.
You go.
It's indicated in asthma, COPD, emphysema, and shortness of breath.
That's not what they asked, Derek.
What's the drug class, Derek?
Oh, I don't know that. I don't know.
Right.
It's an anti-cholinergic.
Yes. Way to
I
go,
couldn't
Chris.
say the word.
A what?
That's Demetria.
Anticholinergic.
Oh.
That was Demetria that said that.
Okay. So what effect does that have on the body? The anticholinergics. What effect does that have on the body? What's it anti working on?
On the cholinergic, it's in the nervous system.
I know it's in the nervous system. What is it?
It's on page 211. It blocks.
Y'all just heard about it. You just heard a video about it.
Yeah, it blocks the cholinergic that is released. What is the word? Help me out.
Okay, so this is working in the nervous system, and this is working on the acetylcholine.
ACH, right? The ACH.
Okay, so it's dealing with that. So albuterol and ipratropium are doing the same thing. They are vasodilating the lung, or they're not vasodilating, but they are bronchodilating the lungs. They are helping ease of work in the lungs to make breathing easier, but they're doing it from two different directions. So albuterol is doing it from the beta 2 side, so it's over there working, and ipratropium is working from the nervous system acetylcholine. Okay, so in most cases we'll give these medications together. What's the dose for ipratropium?
0.5 for adults per neb.
Okay.
Or 2 sprays if you use the spray.
0.5 milligrams, and we'll do that nebulized. In a lot of cases, we'll do the duo neb, and we'll nebulize the 2.5 of albuterol and the 0.5 of ipratropium together. So same indications for use. Any contraindications in ipratropium?
Use of atropine.
What's that?
On the site that I got it from, it says contraindication is use of atropine.
Yes. Anybody know why?
Nope. That's your job to teach us, Cliff.
Yes, because ipratropium and atropine come from the same thing. They are derived from the same plant. So it's almost essentially the same medication. And so again, they're going to be doing the same things. So it's almost like nitro and sexual drugs. So atropine, ipratropium, they work along those same lines. They're essentially the same. Any others? Tachycardia, heart rate goes up, yada, yada, yada.
Hypersensitivity.
Hypersensitivity, that's always. Okay, so dose is 0.5 milligrams or 500 micrograms, however it's said. Route is inhalation. Anybody have anything else for ipratropium? All right, that's all the medications for this week. So you guys you'll have a list of medications every week for like the next 5 or 6. And that'll get you through your entire formulary of medications that are at your disposal, depending on protocol, but it is in your scope of practice. So, any questions about that? Any other questions before we go? I know we're run over just a little bit in time, but we're getting ready to get out of here. So the rest of this week, you guys have a discussion that you need to do. You have your quizzes that you need to do. You have your med list that you need to do. Study for your module exam. That's coming Wednesday, Thursday, Friday, depending on which lab you go to. And we will see you in the labs. All right, last chance. Anybody got anything? Nope. All right, good to see you guys again this week. We will talk to you later.